At Cooper Surgical, we believe every generation deserves a chance to bring new generations to life. That access to quality fertility treatment for all needs to be prioritized globally. And by working together, we can change the access to fertility care to break down the barriers standing in the way of parenthood and push the boundaries of what is possible. To change fertility care, not just for today, but for generations to come.
Good afternoon, I'm Emily Austing, Managing Director of Cooper Surgical Fertility in the UK and Ireland. It gives me great pleasure to welcome you to our Demo Zone talk this afternoon. Speaking today about his recent publication looking into PGT-A outcomes based on HFEA data, we have Professor Darren Griffin from the University of Kent. Professor Griffin is a world leader in cytogenetics and runs a vibrant research lab with 20 colleagues and students. He performed the first successful cytogenetic PGT and played a significant role in the development of carrier mapping. He is president of the International Chromosome and Genome Society, a fellow of the Royal College of Pathologists, the Royal Society of Biology, and the Royal Society of Arts, Manufacture and Commerce, and sits on the faculty of Cogen. Darren, a real pleasure to have you speaking this afternoon. I'll now hand over to you. Thank you.
Thank you very much, Emily. Thank you to Cooper for sponsoring me for this meeting. Very grateful to be here, but gutted not to be joining you all in Liverpool. So first of all, a little bit of conflict of interest statements. Not much there, except to say thank you for Cooper, who also sponsor a couple of students for me. Right, so to give you a little bit of a background, I'm going to tell you a little bit about history of these traffic lights that the HFEA have been implementing, a little bit about our own outcome data, something about the most recent RCT, some progress that we've made in the last year, and then how we interpret the evidence base and tell our patients. So let's do the first of those. Now, I have to say that although I may put out some criticisms of the HFEA about specific issues, I have to say I am very much a vocal proponent of them. We should always value our regulator, even though they do frustrate us from time to time. Just look, for instance, at the role that the regulator played in getting the COVID vaccines approved. And the work of the HFEA in general terms has been one of the reasons why the UK has been a world leader in the world of IVFs. So sensible regulation alongside cutting edge science and medicine. However, I'm sure we're all aware of this particular situation, the one of traffic lights. Now, what I'm showing you here is the old screenshot, and it pertained to this some time ago. In that, if you look at the so-called add-ons, I personally don't like that term. I think it's really quite derogatory. Nonetheless, it's the one that is used. You can see a couple of things. First of all, in the old livery here, we look all the way down and we don't see a green light. The second thing is that we notice that by PGT-A, there were 2 red lights. Now, I'm inclined to think that if you were just put nothing but red and yellow lights around a situation, then you may well get in a situation like this. And some time ago, a little over a year ago, this was the guidance for PGT-A, which they were still using the term PGS at the time. Now, I'm very grateful to the HFEA for receiving me not once but twice this year, and this was a talk that I gave to them entitled Who Guards the Guards? This is me sitting in my little cabin at the end of my office in the middle of lockdown number 2, and I put this slide to them, and I suggested to them that there were a number of things with the traffic light system that were not a good look. The first one I've just mentioned, no green lights. The second one, using outdated terminology, not great. Thirdly, one of the committee members was heard to have said there was no evidence that will convince me that this is effective. The use of not really recognizing things like the non-selection trial, not really recognizing the work of some of the randomized controlled trials, things like endometrial scratch, which I believe has far less evidence for its efficacy than, say, PGT-A, was getting its highest mark. I don't like the phrase, there's no evidence that it is safe, because that implies you think it's unsafe. I don't like the phrase, no evidence that is effective, because that was factually incorrect. And what I'm going to present to you today is the data that we've gathered from the HFEA's own raw data. The other thing that I think is not a good look for them is that on some parts of their website, it's very clear that PGT-A is, and it is a licensed technique, but then to give it a red light. At the time, I believe that cumulative pregnancy rate was something that was looked at over above all things. Now, I may be wrong about that. But also, and then finally on this, I said to them, well, you know, companies can often be reluctant to perform ICTs if all you're ever going to do is give them a red or an orange light. So with that in mind, my slide isn't changing. I'm disconnected. Sorry, my slide doesn't want to go. Okay, so with that in mind, I produced something for the newsletter. I'm afraid my my little PowerPoint thingy is not working, so I'm going to have to ask you to next slide for me, if that's okay. I produced this. So if you just click on that for me again, thank you. Making the point that to say there is no evidence really is factually correct. And I think that was such a shame that they would use that phraseology. Next slide, please. Okay, because this is the evidence base. There are something like around 100 retrospective studies just involving either ACTH or NGS. Let's stop talking about the fish studies. They're no longer relevant. With new data that I presented this time last year, and most of which were reporting a beneficial effect of PGT-A. There are ICTs out there, 8 in total. I'm going to talk about one of them today. Yes, there are mixed results, but at least there's some positive news in there. We know there are non-selection trials out there, which if you look at the far right-hand side of the middle of my slide there, you see that embryos diagnosed as completely aneuploid, 5 out of 5 cells, in this study had no chance of leading to a live birth. There are multi-center analyses, one of which I'm going to present to you today. So I would argue that the balance of evidence seems to be only in one direction. Next slide, if you would, please. Okay, so the HFEA outcome data. Next slide. Now, this study really, you'll see that it was published in JOG earlier, so the end of last year, and it was a result of a Freedom of Information request to the HFEA to look at their data from 2016 to 2018. Next slide, if you would. Okay, so first of all, to say that these groups had a slightly different demographic in terms of their age range. So it won't surprise you to hear that the PGT-A group had more older patients in it, whereas the regular IVF group had less patients in it. And there was something like 2,500 in the PGT-A group and something like 190,000 in the regular IVF group. Next slide, please. First point is that it seems that PGT-A is by and large encouraging the transfer of just one embryo, whereas particularly in the older age groups, it was becoming commonplace often to transfer 2 embryos. And for the complications associated with multiple pregnancies, we like to think that that may well be an advantage of PGT-A that isn't always lauded. Next slide, if we could. Then, the number of times in which an embryo with 5 or 5 cells diagnosed, we know from the non-selection trials that these, by and large, can usually not lead to live births. You see, particularly in the older age groups, the proportion in the darker color there was greater in the PGT-A group, which may well be a good thing. Next slide, if you would. But these are the color results. First of all, the pregnancy rate per embryo transferred, and you can see in each of these cases it's highly significantly greater in the PGT-A group compared to the non-PGT-A group, and the significance is, the p-value is less than 0.001. Next slide, if you would. Okay, now this is the pregnancy rate per treatment cycle. And you see, sorry, I beg your pardon, the live birth rate per treatment cycle. And you can see again that each of these is statistically significant, even in the under 35 age group. Now, I appreciate that this is not a randomized trial. However, in order for you not to conclude that the PGT-A is effective in this case, then you would have to say, well, A, why are we getting this age effect? And B, this would mean that you were inadvertently selecting better prognosis patients in your PGT-A group. And I don't really think that that's true. So next slide, if you would. So what it tells us is, at the time, something like 1.5% of all cases in the UK are PGT-A. All live birth rate differences are statistically significant, even in the under 35s, even for the per treatment cycle. This tells a very similar story to the SART data and the age breakdown of the STAR trial and to non-selection trials. It facilitates single embryo transfer, and it also identifies instances where no embryo is suitable for transfer. Okay, next slide, if you would. And next again. So our most recent RCT, many of you will be aware, was published in about the same week. And this was published in the New England Journal of Medicine, Yan et al., in which the bottom line is they concluded no difference between PGT-A and control groups. Next slide, if you would. It is, without doubt, a well-designed, good study. However, I would point out to you that, first of all the patients are of good prognosis. They are all, on average, of 29 years old, and the study only measures cumulative pregnancy rate. Next slide, if you would. So I'm reminded of this quote by John Cleese. Yes, that's the one, thank you. Reminded of this quote by John Cleese, then yes, of course, a randomized control trial will not show any effect in this case. Next slide, if you would. The referral categories for PGT-A, if I can just remind you, are advanced maternal age, recurrent pregnancy loss, recurrent implantation failure, male chapter infertility. So PGT-A was only ever designed to improve pregnancy rate per embryo transfer, time to first pregnancy, miscarriage rate, and normal live birth rate. Next slide. So I'm a little disturbed with commentaries like this, which accompanied the paper, that really sort of said, oh, you know, we were right all along. And I don't think that was entirely fair. So next, if you would. And even then, when you consider those the study there, and you look a little bit into the supplementary data, then you find something quite interesting. And that actually the live birth rate per embryo transfers in the first and second transfers were in fact greater in this group, even in this trial, even though they were all good prognosis patients. Next, if you would. Okay, so that's and next again. So a few home truths here. Click again. The COVID vaccine does not protect against HIV. Next. Homeopathy does not cure cancer. Next. The Easter Bunny does not bring Christmas presents. Next. So PGT-A was never designed for good prognosis young patients, and it was never designed to improve cumulative pregnancy rate. Next one, if you would. So the progress in the last year, I'm running out of time a little bit because I was fiddling with technology, is to their credit, the HFEA did receive me twice, and things are changing. You will, some of them have changed. Some of them, in my personal opinion, require a little bit more work. But next one, if you would. You will notice now that the terminology has changed, that there is only one red light, and it specifies now that it is from RCTs only. Now, I'm still a little bit worried about this, if I'm absolutely honest, because I think if you put up a red light, you're saying, don't do this. And I don't think that's entirely fair, particularly in another part of your website, your licensing and procedure. However, that is something that we are talking about. Next slide, if you would. So if anybody would like to read it, this is an opinion piece I put about RCTs and reproductive medicine in general and their value. Next slide. Next slide, if you would. Thank you. So now just to finish off with interpreting the evidence base, single center and cohort retrospective study largely point to higher implantation rates and live birth rates following PGT-A, okay, per cycle and per embryo transferred, especially in the advanced maternal age category. Multi-center analysis suggests that it's better for the over 35s, but our new data suggests that it might even have effect for the under 35. The non-selection trial provides strong evidence that the aneuploid embryos are likely to develop to live births. We've also done some cattle studies on this. The RCTs are a little bit mixed, but there is in there some positive benefits. So I believe the balance of evidence appears to favor PGT-A for these categories. Next one. So does PGT-A work, and what do we tell our patients? For advanced maternal age, I would say probably. For recurrent implantation failure and recurrent pregnancy loss, then possibly. Male infertility, I think the jury is still out. Routine IVF, I would say not yet, but we can always improve it. We do need to tell our patients that the HFEA traffic lights have been subject to some criticism. Okay, next slide. Okay, so how do we make it better? We interpret the data as best we can. I will talk tomorrow a little bit more about mosaicism when I repeat this talk. We need to make sure we don't damage our embryos by biopsying them, because we can do that. We need to listen to one another's point of view, embrace new innovations, but importantly, have a sensible and collegial discussion with the HFEA, which I think we're doing. And my very last slide, if you would. And with that in mind, I'll thank you for your attention, and with a very big shout out for my PhD supervisor, sorely missed, Professor Joy Delhanty. Thank you very much.
Darren, thank you very much for your presentation this afternoon. If you're interested to hear more and pose questions to Darren, please join us tomorrow at 12 p.m. for our symposium. We'll also be discussing how IVF mismatches can be prevented and how genetic testing can confirm their prevention. Thank you very much for joining us today, and I look forward to seeing you again tomorrow.